MA hymn and the OCMS hymn.
Heavenly Father, thank you for gathering us in this very blessed day. We are always so grateful for all of your blessings and your continued care and guidance, that you can unconditionally provide each one of us. Forgive us of our shortcomings, and for those times we tend to be selfish and hurtful of others. Bless our organizers and our speakers. Bless our guests and all of our families. Grant us your grace to continue to be steadfast in our fight against deadly diseases, most especially cancer. As we continue to be united in providing care for people who have been affected by this pandemic, help us not to lose sight of other patients who need our help, mostly our patients suffering from cancer. We pray for you to give us knowledge and optimism to overcome this difficult battle. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Puso ko'y tinig ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Ilalangin natin ang tapat sa may kapal, ay lunas sa lahat. Awit ng DNA, tayo ay mag-iwan. Magtulungan, pagunlad ng bayan. Ang kailangan, ibigay sa kanan. Kalusugan at kasaganaan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Ilalangin natin ang tapat sa may kapal, may lunas sa lahat. Ilalangin natin ang tapat sa may kapal, may lunas sa lahat.
Namin sa may kapal, pagkabay niya ang pinagdarasal, tungkulin namin ay ang maglingkod sa mga mamamayan ng aming lungsod. Kami ang mga manggagamot ng Olongapo. OCMS, karamdaman may lunas. OCMS, ano man ang dinaranas, lahat ay gagawin para sa pagaling. OCMS, patungo sa hinaharap. OCMS, kalusugan naming pangarap. Sino pa ang tungkulin ay tutuparin. Kami ang OCMS.
Once again, good afternoon to all our guests this afternoon. Before we begin, I'd like to give you a recap of the usual webinar rules. So as I mentioned, kindly keep your webcams off during the lecture proper. Kindly type in your questions in the chat box for the Q&A, and you may turn on your cameras during the Q&A portion. Keep yourselves on mute mode. And if there are any connection difficulties, just log out, then re-register by clicking on the link, the underlined portion in your Zoom links, or type in the Zoom ID and your password as forwarded to you through the different platforms of the social media. So for our webinar, for a lecture this afternoon, I'd like to introduce our moderator, who will also be giving his opening remarks to formally open this afternoon's lecture. He graduated medicine, Doctor of Medicine from UST Faculty of Medicine and Surgery, and had his residency training in general surgery at the same institution. He is currently an examiner of the Philippine Board of Surgery, the past president of the Philippine College of Surgeons Central Luzon chapter, a past governor for Central Luzon of the Philippine College of Surgeons, and currently the president of the Olongapo City Medical Society. Without further ado, may I call Dr. Raymond Joseph Manzo.
Good afternoon, and thank you, Madam Secretary. Good afternoon to all our participants today, doctors and guests alike. The Olongapo City Medical Society has been conducting its monthly cancer lectures at the beginning of the fiscal year last June. This is in line with the Board of Officers' cancer advocacy to disseminate information and awareness not only of diagnosis and treatment, but more importantly, prevention and screening of this deadly disease. We already had a total of 4 lectures, namely on prostate, pancreatic, thyroid, and bone cancers. And next week, we are scheduled to have our ovarian and uterine lecture. You may follow our Facebook page for announcements on the succeeding lectures and ask your family, friends, and relatives to join us. This is all for free. Breast cancer has already surpassed lung cancer as the most common malignancy worldwide, according to the Globocan in 2020. It comprises almost 1/4 of all cancer diagnoses. And in the Philippines, the worldwide demographic is also true in our country, with approximately 17.6% of cancer cases diagnosed and a 9.3% mortality rate. This afternoon, we have experts on this disease in the field of breast cancer who will enlighten us on how to beat the seemingly unbeatable cancer. We will also hear from a strong woman on how she beat the odds in fighting her own battle against breast cancer through the years. Let me introduce to you our first speaker. He is a graduate of the Fellowship in Medical Oncology in 1999 at the UP PGH. He is the chairman of the Philippine Board of Medical Oncology and the chairman and co-founder of the Subic Olongapo Cancer Foundation Incorporated. He is currently affiliated with James L. Gordon Memorial Hospital, Ace Bay Point Medical Center, the Medical City Clark, and the National Kidney and Transplant Institute. Let us all give our virtual applause to Dr. Jaime Jesus Rojo. Dr. Rojo, the virtual floor is yours.
Thank you, RJ. Let me share my screen. Is it on? Can you confirm?
Yes, Doc, it's clear.
Okay, thank you. So before I start, I'd like to congratulate the OCMS. It's been a really busy year. You have a honest to goodness advocacy there, and really, in behalf of SOCFI, congratulations, and we will continue to support and work with you on your cancer advocacy. So before I start, thank you to all the participants, and welcome to another cancer session of the OCMS. I usually lecture in English, but I'll try na gawing Taglish, no, para mas relax tayo. You will see some numbers, some figures. I can't avoid to be a little bit technical, but I'll try to be simple yet very concise. So the title is Prevention, Early Detection, and Treatment of Breast Cancer. So what is breast cancer? It is an abnormal growth of cells in the breast, like you see here. And when you say cancer, it's malignant as opposed to a benign tumor. A cancerous versus a benign na bukol. When you say malignant or cancer, it means that the growth is out of control. The usual mechanisms of the body is not able to control it. And may end palagi. It's able to invade tissues. No? Kinakain niya yung surroundings niya. It can invade from one area to another. And it has the ability to metastasize. That is, kaya niyang kumalat to other parts of the body. And that's why it's dreaded and sometimes deadly disease. Breast cancer is mostly diagnosed in women, mostly, because 2 to 5% can be diagnosed in males as well. So the lifetime risk, the biggest risk really for having breast cancer is just being a female. And in this slide, it says it's 1 out of 10. Your lifetime risk is about actually 1 in 8. No? The reason why I changed that is because mas updated yan. It's just to emphasize the fact that the incidence rates are increasing, as mentioned earlier by Dr. Manzo. So in this slide also, I can show you already the stages. No? 1, it's palaki siya ng palaki. No? 1, and then kumakalat siya. This is stage 1. Stage 2, a slightly bigger tumor And then meron na siyang spread to the lymph nodes. An even bigger tumor will be a stage 3, including the lymph nodes. And then when it starts to metastasize, kumalat sa ibang part ng katawan, that will be stage 4. So right now, for this session, we would like to concentrate on early or even up to non-metastatic. Ito lang tayo. Ito lang pag-usapan natin. So some facts on breast cancer, na-mention in it Dr. Manzo kanina. It's globally the number one most common cause of diagnosis and death in women globally and here in the Philippines. However, the good news really is death rates are declining with early detection and increased awareness. And that's the reason why we have these sessions, to spread the information, reliable information to you about this disease. And women who regularly get screened for breast cancer have a 47% lower risk of dying. So you can slash that risk already by half. If you know early detection, actually prevention and early detection, to get on a treatment while it's early and get cured of the disease. Again, the most significant factor is being female and aging. So as you age, you will have, depending on where you are here in the Philippines, I think it's already 40, and rightfully so. Dapat naman, palagi kasi tayo nahuhuli sa mga guidance natin sa ating publiko. But really, the risk starts at 40. So the screening and early detection programs are started at 40. Ngayon, if you have a higher risk, halimbawa, trans in the family, meron kayong cancer gene na detect by testing, and then you can be started at an earlier age. So some facts, these are survival rates. Ano ba yung chance mo na mag-survive beyond 5 years? This is by no means a tanning. At 5 years, ano yung chance mo na mabuhay? Buhay ka with breast cancer. Depende kung saan ka nakatira. So, bakit may ganun? Because, it's an unequal distribution of knowledge and wealth all over the world. So as you can see on this side, sa kaliwa, these are the advanced countries. And habang bumababa yung mga less developed countries. So this is 2000 to 2003, and already European and the rest of the Western world are already above 90%, meaning halos walang nang mamamatay. In fact, I remember noong 2005, I was in the States attending a convention, and there they said by the year 2020, no American will die of breast cancer. That is because of a new development at that time in treatment of early breast cancer. Is that going to happen? Actually, 2021 na. It did happen, but they're close to that. No system is perfect. There's also another group who put a deadline of 2022 to finding the cure for breast cancer. I think that's rather more rhetorical, but that's not gonna happen. However, we're making great strides, and we're getting closer and closer to that. Like this one, this is a more updated data from the US. Ito yung CR data nila. And indeed, if you just look at the localized, yung early breast cancer, indeed, that's halos totoo na yung sinabi nila. 98.9% 5-year survival. So if you catch it early, huwag mo nang palakihin. But even if medyo malaki, nakapa mo. And 85% pa rin. If you treat yourself right, remember, this is the US. So how are we doing? Nasaan kaya tayo? Okay, here's a graph that I recently downloaded. You see the arrows here. Our cancer information is basically gathered only in Manila, and that's the Manila Rizal Cancer Registry. And you can see that ang information that we have And this is, I think, very new. Latest 2015. That's very new for the Philippines. Wala na sumunod after. Is 37 to 50%. So if you average it, we're not doing really well. Ibig sabihin, more than kalahati will not make it. So these are because of factors that we can actually correct. And one of those is attending these meetings, and getting information and having yourself started on a breast screening program. So let's discuss the risk factors. Medyo complicated yung slide, no? However, concentrate on this part first. These are the upper part of this slide. You will see the risk factors that you cannot control. However, for you to be aware, is some kind of control. Kasi mag-iingat ka and you take your surveillance, your screening seriously. What is gender? Na-mention na nga kanina, and age. Pataas ng pataas yan. Genetic factors. If you see a lot of the same cancer in your family, or even related cancer of the prostate, ovarian, yung female reproductive tract, there is a good chance na meron kayong genetic susceptibility, especially if you're seeing breast cancers very early, 30s, under 50, that's the threshold, Ibig sabihin, meron kayong susceptibility gene, if not really the breast cancer gene na meron. Other one, if you start your menarche, yung unang regla, very early, this means kasi that your body is exposed to fluctuations, yung pag-increase ng estrogen on a monthly basis, the female hormone, which is connected to the menses. So this is an on switch, which we will discuss later, for the breast and the female reproductive tract. So on off, no? If you start it early, then mas maaga kang magkakaroon ng problema. Family history, I mentioned earlier, then yung late menopause, again, this is connected to the cycling of estrogen, yung monthly menses. And if you in the past received radiation for any other reason, radiotherapy to the chest, na exposure. So what are the risk factors that you can control? One is having no children. That's a risk factor. So breast cancer is high incidence sa mga hindi nag-anak for any for whatever reason. That is because pag yung pregnancy, it breaks the cycle of the estrogen na monthly tumataas during the pregnancy and the few months after that, including the time that the woman is breastfeeding, mababa yung estrogen. So it tends to be protective. And then again, hindi man nag-anak, yung when late ka naman nag-anak, that is after 35, not breastfeeding, using replacement or anti-reproductive hormones, unhealthy diet, lack of exercise, and obesity. These are known risk factors for breast cancer. You can control this. And of course, primary prevention. That's exercise as a way to control, to prevent. Maintaining a healthy weight, limiting alcohol, and again, a really healthy diet will prevent breast cancer. So again, this is one of considered a lifestyle disease, like a lot of cancers are. So in this slide, maintaining a healthy weight, staying physically active, healthy diet, meaning lots of fruits and vegetables, smoking, no smoking, and limiting the alcohol. So what are the signs or symptoms of breast cancer? I usually skip this. However, I have to show you, because when you see this, medyo late na sila. But kung hindi mo na-detect, even if you are on a screening program, it doesn't mean na makakalusot siya doon in the interim na hindi ka nag-screen, in between your screening. So, nipple discharge, growth of veins on the breast, puckering, yung iba yung nagkaroon ng dimple, redness, recess, ito mas malalim. And then nag-change yung size, biglang asymmetrical ka na, or nadagdagan yung asymmetry, retraction of the nipple, lumubog yung nipple bigla. Thinning of the skin, retraction of the skin, again ito, no? And yung outright na nabutas na yung skin. These are signs that something invasive, no, is growing in the breast. However, bago natin maano yun, maabutan yung ganong stage, no? If breast cancer is detected early, like I showed you earlier, the USA CR data, there is almost a 100% chance that you will survive it at 5 years. Pag kasi 5 years ko palagi sinasabi. Because when you get breast cancer, the highest risk of nababalik siya or giving you more problems is in the first 3 years. No? And then after the 5th year, basically, mababa na. So, yun yung usual point na tingnan natin on 5 years. So again, monthly early detection plans should include monthly breast self-exam. In the Philippines, we advocate this. Regular clinical breast exam, that is a yearly na clinical breast examination that will coincide with the rest of your other examination. Which you should do on a yearly basis naman. And then mammograms. No? I will go to a little bit of this in detail. Again, depending on your age, but the usual start is 40. This is the breast self-exam. This is a method. This is an example of the self-exam method. You can do this monthly. That's the position, fingertips like this close together. Gently probe each of the breasts in any of these patterns. And then the main tool for screening is sonomammography. Dati dalawang word yan. Ngayon, isa na lang. No? Because one is complementary to the other. It makes the combination is more sensitive and more specific when we do that. So, naging one word na yan over the year, sonomammography. You use two machines separately, no? Mammogram and an ultrasound. Itong image na to, this is an X-ray. This is the mammogram part. So, sonomammography is quick, generally painless, and inexpensive. It is actually considered painless, but I know that some of you feel no masakit nga siya actually. So that's why I say generally painless, pero not really na super painful. No? So do not be afraid to get tested if you need it. So when you receive a report, don't mind that, pang doctor naman yan. But you will see that your report should be in numbers. Yun yung tinatawag na BIRADS reporting. 0, 1, 2, 3, 4, 5. Yan agad ang tingnan ninyo when you get the sono and mammo. And yung nakakatakot dyan are ito, 4 and 5. Meaning, yung tsura niya on the image is not good. Meron siya mga hallmark na mga itsura. That means na pag probably benign, 3 short interval follow-up, usually 6 months. So, ibig sabihin, ulitin natin after 6 months. If there are any changes, then you might get biopsy. If stable siya, pwedeng, okay, let's just continue on monitoring this lesion. Pag 4, tissue diagnosis, meaning magbabiopsy ka na. And buti naman, nakita, di ba? So, yun yung beauty ng technology na to, that you will see breast cancer or any other related, kahit hindi pa siya cancer, precancerous na lesions, and have it treated outright, bago mo pa siya makapa. That's why I say, usually I'd like to skip that slide na kung saan butas na, etc. Parang it gives you a false sense of security that when you know these things, na you'll be fine. So wag mo na hintayin yon. Go to sonomammography and just look at these numbers, and you will do, just like the numbers say, 47% reduction in the risk of dying, and nearly 100%, 5-year survival. So how is it treated pag na-detect na? So this is a really nice na slide, from tagal na pala, alam na natin yung breast cancer. Kaya yung naging symbol ng cancer is crab. Sabi nila kasi dati it grows like that. Kita niyo yung picture kanina, parang pag nag-grow sa breast kasi puro ugat siya. Mukha siyang crab, no? And then 17th and 19th 17th century pa pala, no, nasimula na siyang operahan, no, ng mga Surehano nung panahon na yun. And then yan, naging radical surgery initially, no, pagalingan mag-opera. And then later on, we do less surgeries, no. Dr. Mallen will talk about that later, no. Naging less radical na yung mga treatment. And then pumasok na yung chemotherapy. Yung chemotherapy is initially na-discovered nila, uy, napapaliit natin yung mga tumors, yung mga stage 4. And then they said, okay, why not try them on post-op? Yung mga na-operahan, yung mga napagaling na, tinry nila. And then nakita nila na, nag-decrease yung mga recurrences and nag-prolong yung overall survival nila. Meaning, ang assumption kasi is, from the beginning, meron na siyang mga microscopic na hindi na undetectable, no, still to date, up to now, ng technology. Pero the proof of that is that pag binigyan mo ng chemo after surgery, maba yung buhay nila. Ibig sabihin, may tendency talagang matira. And that was in the 80s and the 90s. And then what's new now, just entered therapeutics, no, this year and last year, is yung targeted and immunotherapy. No? They're already entering the galing sa stage 4, quite successful, no? Super successful in stage 4. Now we have additional armamentarium to chemotherapy that's targeted in immunotherapy, and we are already using this in early and regional breast cancer. So again, no, when you get breast cancer, you will be treated either by surgery, systemic therapy, that means may chemo, hormonal, anti-estrogen, no, targeted, and immunotherapy or radiation therapy. Any combination of this. The smallest of tumors, surgery lang sila. Lumaki ng konti, surgery plus systemic therapy, either hormones or chemo, no, and then targeted or immuno, possibly. And then, mas malaki pa, then you get all surgery, systemic therapy, and radiation therapy. So I usually ask, now my nurses know this when I interview, gaano po ba kalaki? Gisantes ba, mani, o daya? This is from the National Cancer Institute in the States. Estudyante pa yata ako ng oncology, we've been using this already. But just to show you, yung title nitong slide, ano ba dyan yung kung operahan na? Tama na ba yung opera lang? Ayoko sana mag-chemo. Actually, ito yung threshold, no? From siguro about 20 years ago. If it's bigger than a P, gisantes, tama ba yan? Malaki yata yung gisantes, green P, no? Ay chemo na yan or hormonal therapy. In fact, pag merong mga high-risk factors pa yung tumor mo, it's really that eraser head, no? Yun ang threshold size. Malamang mag-chemo ka na. And that's the beauty of early detection. Kasi dito nakikita na yung cancer. Kung takot ka sa chemo, so huwag mong ayaan, no, na lumaki siya beyond, no, the eraser head size. So, what factors tell you, no, kung madadagdagan yung surgery after surgery? Ano pang kailangan ka pa ng any further treatment? One is yung stage na pag-usapan na natin kanina, yung gaano ba kalaki yung tumor, nag-spread na ba siya sa mga lymph nodes? Ito kasi yung drainage system niya. The other one is histopathology. Pag na-operahan ka, may report yan. May mga details doon. Siyempre, naintindihan mo lang, natakot ka. Yung nakalagay doon na breast cancer, invasive ductal carcinoma, nakalagay. Pero the doctor, no, kami nila, Dr. Mallen, Dr. Manzo, we look at the details there, no. One is grade, no. Ano ba yung grade? Sometimes may mistake nila kasi 1, 2, 3 rin siya. Grade is how aggressive it looks, no, under the microscope. Makikita mo yung behavior niya base sa kung gaano siya hindi sa abnormal under the microscope. So this is a risk feature, no. Pagka high grade yung tumor, then that high risk. Then even if maliit, no, eraser head size, then you'll probably get chemo after. And then ito yung biomarker, no, dapat alam natin lahat to. Ang cells kasi, including tumors, no, they're super sophisticated machines, no? Much more sophisticated than any human can make. And meron silang switches. No? Kanina napag-usapan natin yung estrogen, ito siya. Doon siya nag-a-attach doon sa socket na yun. Pag nag-attach siya dyan, grow. Yan ang sinasabi niya ng cell. It's for normal cells, ganun. And then for cancer cells, ganun din. Titingnan yung cancer na tinanggal sa patient, kung meron siya nun switch na yon, then therefore, pag meron, then it can be suppressed by an anti-estrogen. Meaning, in your treatment, there will be a mix. In the mix, meron na siyang anti-estrogen. Similar yung estrogen and progesterone, they're both hormonal receptors. No? Yung nag-develop noong 2005, which really pushed breast cancer to nearly 100% cure, is HER2. No? Like triangle dyan pupunta, may anti-HER2 na gamot na ibibigay sa pasyente. And so positive or negative, no, we look at it yung different combinations, no. And aside from yung anong gamot ang pwede namin ibigay, how aggressive we will treat, ano yung bagay na chemotherapy sa kanila, it affects prognosis. So meron yan, no, meron siyang meaning. So I wrote them down here, no, mula doon sa pinaka less aggressive to the most aggressive, no. So pag positive siya for estrogen, for the hormones, kasi pwede mo siyang targetin, then that's good, no. Yan, ER and PR positive. Yung HER2 is negative yan. Pagka may positive ka niyan, that's a bad indicator. Mabuti na lang may gamot na. So, HER2, anti-HER2 bibigyan mo. Yung pag triple negative, yung negative silang lahat, may tendency yan maging mas aggressive. Then therefore, chemotherapy lang ang pwede sa'yo. Then, you will receive a rather aggressive chemotherapy to make up for that, no? Kasi you cannot be treated with other available technology. So, kumbaga I always tell my patients, no, yung histopath report, no, it's like a birth certificate. No? Ito yung first name, ito yung first name niya, ito yung surname niya, ito yung middle name. You cannot be treated. Even yung sequence, no, ano ba mauna, chemo ba o surgery? No? You will not really know until you know this, yung biomarker status. No? So always ask, no, if you get a diagnosis, ano ba yung biomarker status ko? Then this will enable you to plan very well. And this is the key to cure. No? Hindi pwedeng hindi ginagawa. And more technologies, no, for us, no, for the very early breast cancer. Meron mga new technologies wherein they will check you for about 80, 75 mutations, yung genetic mutations ng tumor. And then meron siyang risk scoring na maaari kang makatakas sa chemo. If yung stage, no, and histopath, no, yung kaninang are saying na malamang mag-chemo. Teka muna, baka naman pwedeng hindi. Not that chemo is nakakatakot sobrang. However, if there are this is new technology na titingnan natin yung mutations and then there will be combinations wherein low risk ka, makakatakas ka sa chemotherapy. These are the latest developments in breast cancer na are getting into, no, our practice here in the Philippines. The only problem dito kasi is cost. If you need to know details later, pwede, no, you can ask in the Q&A. So what is chemotherapy? That is what I do. Nauna lang ako magsalita, pero si Dr. Mallen, siya naman yung magaling sa surgery of breast cancer. So pag sinabing chemotherapy is loosely used minsan, no, na to mean yung nasabi ko na kanina, hormonal therapy most of the time, ito ay tableta lamang. Pag sinabing chemotherapy, these are cytotoxic, no, na gamot na binibigay by IV, either direct injection o aswero. So kumakalat siya sa bloodstream, siyempre papasok sa gut, no, or sa dugo. And then that's why it's systemic. No? So lahat ng natira dyan, kung early, and then ubusin niya yan. And then that decreases your recurrence rates. So I'm nearing the end of my talk. No? This is our chemo unit. No? Ba't ko ba nilagay yan dyan? COVID and pre-COVID. No? We continue to work. We never stopped a day. No? We never lost a day because of this pandemic. We continue to help patients. Hanggang ngayon, no? Walang hinto kami nila Dr. Mallen. And it's not that bad. No? That's the reason why I put that really. It's not that bad to get chemotherapy. Like you see here, nakaswero siya, nagbabasa siya ng book. Totoo yan. No? You can see in our chemo unit, may TV, kumakain sila like this girl. No? You can eat there. Sandali lang siya. No, you don't need to be admitted. That's chemotherapy for early breast cancer. So my last slide, the best protection really is early detection and primary prevention. It's a lifestyle disease. Then therefore, eat healthy, live healthy, exercise, lose weight, no, if you are overweight, and that will help prevent breast cancer. Maraming salamat po.
Thank you, Dr. Rojo, for that very informative lecture. Halo, lay, and pang-doktor talaga yung lecture.
Thank you.
Thank you. So before we go to the Q&A, we have another speaker. Let me share again my... Okay, so let me introduce our next speaker. Our second speaker is a good friend of mine, one of my senior resident, our very own surgical oncologist in Olongapo. He's a graduate of Doctor of Medicine in UST, Faculty of Medicine and Surgery, and had his training in general surgery in 2007 at the same institution. He graduated Surgical Oncology Fellowship at UPPGH last 2010. And he is a fellow of the Philippine College of Surgeons, Philippine Society of General Surgeons, Surgical Oncology Society of the Philippines, a charter fellow of the Philippine Breast Cancer Society and the American College of Surgeons. He is also an examiner of the Philippine Board of Surgery and currently the auditor of the PSGS Metro Manila chapter. Let us all give our virtual applause to Dr. Richard Mallen. Dr. Mallen, you have the floor.
Thank you, Dr. Manzo. Let me start let me share my screen na. Is it on?
Yes.
Okay. So, good afternoon. So, I was tasked to give a lecture about the surgery for breast cancer. So, sabi ni Dr. Rojo, medyo technical sa kanya. Yung nagawa kong lecture, medyo mas technical. So, I will just try to discuss it in layman's term. So, okay. So, some of my slides are already mentioned. So, the incidence of breast cancer, it was already mentioned by Dr. Manzo. It's the most common at present worldwide. Okay, so these slides is also discussed by Dr. Rojo. So, yung signs and symptoms ng breast cancer. So, not necessarily naman na pag meron ka is automatic cancer. It's a warning sign, no? Not all tumors or bukol are malignant. So some are benign naman. So yung inverted nipple, some individuals are may inverted nipple talaga. So pag meron kayong ganito na napansin, ang ibig sabihin lang it just warrants further investigation. Okay, so For the screening, again, ano na ni Dr. Rojo, dadaanan ko lang ng mabilis siguro. Mammography, it can detect non-palpable masses, so meaning before the start of symptoms. No? It usually helps us, it adds or supplements the history taking and the physical examination. So mentioned also by Dr. Rojo, screening starts at 40 years old. Okay. Next is ultrasound. So combination na siya talaga yung sonomammography na that was mentioned also by Dr. Rojo. For the ultrasound, it is usually used to resolve equivocal findings in mammography. It is used to define cystic masses and demonstrate echogenic qualities of specific solid abnormalities. Ultrasound usually is better in dense breasts. No? So that's why it is usually the screening tool for young females, less than 40 years old, because their breasts are much dense compared to an elderly. Okay? When we are trying to assess the axilla, yung kilikili, kung may mga kulani, it is also better compared to mammography. Okay. So other imaging technique that are we use to detect breast lesions are breast MRI. Breast MRI, it is usually used for high-risk women, those with strong family history, or those who are carriers of genetic mutations. It can be used also in when there is an abnormality not seen in mammography and ultrasound. Usually, it has a sensitivity of 100% and specificity of 98.1% for patients na binasahan ng BI-RAD 0. Kung halimbawa sa ultrasound, BI-RAD 0, yung minention ni Dr. Rojo kanina, yung scoring, and mammogram, BI-RAD 0 din. So ibig sabihin, kailangan ng further investigation. So next step is doing an MRI. So next. So another imaging technique, is ductography. This is not common, but I tried to include lang rin yung mga ibang mga test pa na ginagamit natin in the detection of breast cancer. Usually, ductography is used in patients na may history ng may lumalabas na dugo sa nipple. So may mga pasyenteng gano'n na ang complaint hindi bukol but bloody nipple discharge. So when you do ultrasound and mammogram, walang nakitang bukol, ang next step is to do a ductography. So they try to cannulate yung butas na nilalabasan ng dugo, then they put a dye o yung parang gamot, and then take an x-ray na parang mammogram din. So they will be able to see kung saan yung pinanggagalingan yung ducts involved. So the most common cause ng bloody nipple discharge yung tinatawag na intraductal papilloma. They are benign and can be managed with excision alone. Okay. So this slide ay na-discuss na to ni Dr. Rojo. So for the biopsy is the process of getting a sample of the tumor so that it can be evaluated by the pathologist. So for breast tumors, we usually label it as palpable and non-palpable. The process of doing biopsy will differ between the two. Sorry. So, yung mga nakakapangbukol, ito yung mga usual na ginagawa naming ways to do biopsy. Core needle, yung mga dati is doing just a fine needle aspiration biopsy. Excision biopsy, meaning taking out the whole tumor, or incisional biopsy, or taking just a sample. Maliit lang. Core needle biopsy is regarded as the standard. Okay? It has the advantage of minimally invasive, tusok lang siya, no? Compared to an excision or incision biopsy, but it can still get a tissue sample instead of just cells or just cytology sample na nakukuha naman from FNAB. For breast cancer, we need the initial specimen to be a tissue specimen so that we can request for the breast panel. So as mentioned by Dr. Rojo, the importance of breast panels in ERPR and HER2/neu, because it is very important in the management, whether we are going to do with surgery or doing chemo muna. So nakadepende doon sa breast panel. Paano naman yung mga hindi nakakapa na lesions? No? Kasi merong mga ganon. Yung advantage nga ng screening using mammogram or ultrasound, makikita agad kung meron ng mga suspicious na lesions. So paano kung merong nakita sa mammogram na BIRADS4? So suspicious yon, ba? So kailangan siya i-biopsy. So paano may iba-biopsy ang hindi nakakapa? No? So in cases like that, kailangan natin yung tulong ng radiologist natin, no? So it's either we do image-guided biopsy habang inu-ultrasound o habang minamammogram, tinutusok yung tumor so that we can get a sample. Or we can do yung wire or needle localization. So ang ginagawa naman doon, ito, tinutusok siya ng special na needle o wire, iiwanan yung wire na yon, then the patient will be brought to the OR, tatanggalin namin, hahabulin namin kung nasan yung wire, yung dulo ng wire na yon. And then pag natanggal siya, we will send it to the pathologist for biopsy. So ito yung dalawang ways to do biopsy for non-palpable lesions. So once we have the results of the biopsy, we then decide on what's the next best step. For benign tumors, we decide if it needs removal or can it be just observed. For malignant lesions or cancers, we start by doing the necessary metastatic workups if needed. Then the decision whether to do an outright surgery versus doing a neoadjuvant treatment comes in. So, yeah, this was mentioned by Dr. Rojo, management of breast cancer. Multi-step siya, marami. So nakalimutan ko dito is the immunotherapy. For my part, I'll be focusing on the surgery. Okay. So I will try to go through these different procedures briefly throughout this session. So madaanan lang natin siya. No? These are the procedures associated with breast cancer. Okay. So mentioned again by Dr. Rojo, there is already a de-escalation of surgery, meaning from the very morbid radical mastectomy up to the present na nasa na tayo ngayon, breast conservation surgery. So for the axilla, ganun din, removal ng halos lahat ng kulani versus just doing a sentinel node o sample lang ng kulani sa kilikili para maiwasan yung mga complications pagka masyadong extensive yung surgery na ginagawa. No? So usually the improvement in the neoadjuvant systemic treatment has helped a lot in the de-escalation of surgery. Okay. Surgery is still the primary treatment for breast cancer, especially the early stage cancer. This involves resection of the primary tumor with negative margins to reduce local recurrence. And then the primary aim of surgical intervention is to achieve local disease control And then the secondary goals is good cosmetic outcome and high patient satisfaction. Okay. Surgery would also provide us with the pathologic stage of the tumor and the axillary node. So pag natanggal na natin yung buccal and the lymph nodes in the axilla, then the pathologists can tell us kung ano yung final stage. No? And then this will provide us with the necessary information and guide us in the choice of the adjuvant treatment. Modified radical mastectomy. This is the most common procedure na ginagawa para sa breast cancer. So ito yung tinatanggal yung suso and tinatanggal yung mga kulani, lahat ng kulani sa aksila, sa kilikili. It is still the most common procedure done in the country. May pag-aaral na ginawa yung PSGS dati in all training institutions worldwide, Manila and the provinces, around 70 to 80% pa rin of procedures done for breast cancer is still mastectomy or yung modified radical mastectomy. It is still accepted. Okay? MRM, so ang ginagawa dito is tinatanggal lahat ng breast tissue on the affected side. Tinatanggal yung nipple areola complex, yung skin, and yung mga kulani. Usually ang kulani may tatlong level sa kilikili. Ang tinatanggal namin usually is level 1 and level 2. So ito yun. No? So sa axillary dissection, tinatanggal namin yung kulani. So makikita nyo may muscle tayo dito sa dibdib. So andyan dyan yung levels 1, 2, and 3. So ang tinatanggal lang namin is 1 and 2. Unless yung 3 is grossly positive din siya. So meron kami minimum number of lymph nodes na kailangan ma-harvest o matanggal, which is 10. Ang normal na kulani dito sa area na to is around siguro at most mga 27. No? So kung matatanggal lahat ng taba dyan sa level 1 and level 2 properly, kung talagang natanggal lahat, so dapat may makukuha tayo at least 10. Yan, no? Isang important na aspect din ng surgery is yung ma-preserve yung mga nerves and yung mga ugat, no? Lalo na yung long thoracic, we call it the long thoracic nerve and the thoracodorsal nerves, which is important in our functions. Okay? So the indications for choosing mastectomy includes those cancers na hindi pwedeng magamot na breast conserving lang, yung tatanggalin yung bukol lang, no? Or those patients na yung radiotherapy is contraindicated, or if there is a desire to avoid radiotherapy. Ito nilagyan ko ng mark kasi medyo i-discuss natin yan later, no? And then for patients who would have poor cosmetic outcome with breast conservation surgery, and those na merong contraindication with BCS. So, ito yun, no? So, para doon sa mga pasyente na ayaw nilang mag-undergo ng mastectomy, para doon sa mga pasyenteng pinili yung mastectomy just to avoid radiation, so dapat kausapin natin sila, no? Dahil yung mga indications for radiotherapy, usually hindi natin alam beforehand. So usually it is dependent on the final pathology. So hindi natin alam na may positive na kulani pala. So pinatanggal mo yung suso para ma-avoid yung sabi mo yung radiation. Pero in the end, pag lumabas yung final na biopsy mo, malalaman na may mga kulani ka pala na positive, mag-i-end up ka pa rin with doing radiation. Saka yung mga indications for radiotherapy, dati ang mga indications, yung number ng kulani na positive dapat 4 or more. Yung tumor dapat nasa 5 meter o yung close margins. Ngayon, kahit na isang kulani lang ang mag-positive, there are recommendations na kailangan mo ng mag-radiation. So, dapat alam lahat ito ng pasyente. Okay. So, aside from MRM, yung tinatanggal yung suso, another option for breast cancer yung tinatawag na breast conservation surgery. In other countries, developed countries, ito yung standard sa kanila. No? Probably because in those areas, most breast cancers are detected at an early stage and are amenable for less than a mastectomy. No? So breast conservation, ang ginagawa ko dito, tinatanggal yung bukol lang pero with margins, meaning bukol na nababalot pa siya ng taba or ng normal na breast tissue. Dapat nasa loob yung tumor. So it can be done using a lumpectomy, a partial segmental mastectomy, or quadrantectomy o yung isang 1/4 nung suso tatanggalin. And then aside dun sa pagtanggal ng bukol, kailangan i-assess din yung mga kulani again for staging. This one in the form of yung tatanggalin yung lahat, yung level 1 and level 2. Or another option is just doing a sentinel node biopsy. Ito naman is kukuha ka lang ng sample, mga 4 na kulani lang, i-check kung may magpa-positive doon, tapos magdi-decide kung kailangan mag-proceed doon sa actual na axillary clearance. We will discuss the sentinel node biopsy later. So the third part of breast conservation surgery is radiation. No? Ito usually yung kaya ayaw to piliin ng pasyente because of radiation. No? So yung pag breast conservation ang pinili natin, yung radiation treatment is a must. No? It's part and parcel of breast conservation. So regardless of your stage, kahit stage 1 lang yan, kahit wala kang kulani, kailangan ma-radiation ka pa rin after. So, this one, lang to, sinasabi lang dito na yung pag tinanggal yung bukol, kailangan yung margins natin is by pathology, walang ink, no? Yung no ink on tumor. Okay? So pagka halimbawang close margins, yung nakuha mo yung bukol na nababalutan lang siya ng manipis na taba, as long as wala siya dun sa ink margin, so no additional surgery needed. These are the contraindications in doing breast conservation surgery. Pregnancy because hindi makakapag-radiation, diffuse suspicious malignant appearing microcalcifications. Diffuse, ibig sabihin medyo kalat siya dun sa breast. So useless na mag-lumpectomy. Again, yung widespread disease that cannot be incorporated by local resection. Those with diffusely positive pathologic margins. And then meron din mga relative contraindications as listed. So, walang difference with regards to survival, yung breast conservation surgery and MRM. Proven na yan ng maraming evidence, maraming studies, maraming clinical trials na no difference in the survival benefit. So, the decision to do breast conservation versus mastectomy will depend on the tumor characteristics. So again, as I mentioned, kung extensive yung classifications niya or multicentric, ibig sabihin hindi lang isa, iba-ibang area siya, so baka hindi pwede ang breast conservation, mastectomy. And then another factor is the ability to obtain clear surgical margins. And the size of the tumor with respect to the breast size. Baka sobrang laki nung bukol, yung breast, katamtaman lang. Pag tinanggal mo yung bukol, baka wala na halos matira. So isa yun sa kinukonsider natin. So ang purpose ng breast conservation is, part of it is aesthetic din, syempre. So pagka tinanggal mo yung sobrang laking bukol, wala na natira, baka lulubog. So hindi rin mako-compromise din yung purpose mo na cosmesis. Okay? So another factor is yung access of radiotherapy. In our area, ang meron lang radiotherapy is ang pinakamalapit is Pampanga in San Fernando and Angeles. Isa to sa mga problem din natin. No? And then of course is patient preference, kung ano yung gusto talaga ng pasyenteng gawin. Yung mga pasyente na merong gusto ng breast conservation but yung bukol nila malaki compared dun sa breast size nila, ang option is pwedeng magbibigay ng chemotherapy si Dr. Rojo para mapapaliit muna, and then pwede siyang babalik for the breast conservation. So isang option yon. Itong slide na to, pinapakita lang na parang how effective yung neoadjuvant therapies at present. So dito as high as 83%, merong complete pathologic response. Halos nawawala na yung bukol pag nag-chemo, especially when using combination chemotherapy and yung targeted treatment na in-explain kanina. Usually, maganda ang effect ng neoadjuvant in patients na merong HER2 positive and those with triple negative breast cancer. So again, we have to emphasize this. Sinabi rin ni Dr. Rojo, that's why important ang breast panel before doing anything. So after ng biopsy, breast panel, so that we can decide kung if we are going to go with surgery outright or if we are going to do a neoadjuvant, meaning chemo muna para liliit muna yung tumor. Okay? So next to breast conservation surgery is oncoplastic surgery. So it is usually used when the surgical defect is large or expected to result in a poor cosmetic outcome. It extends the indication of breast conserving surgery. It permits removal of larger area of the breast tissue, thereby achieving wider surgical margins and at the same time better preserve the appearance and natural shape of the breast. It is just like an extended version of the breast conservation surgery. Special training is necessary to be able to do oncoplastic techniques. So, sa Manila, meron na tayong mga breast surgeons na trained to do oncoplastic surgery. Okay. Yung issue between in doing oncoplastic breast conservation is the same with the standard breast conservation surgery, which is yung recurrence rate, yung relapse, o kung babalik ba yan pagka ang iniwan mo yung suso, no? So ito isang study lang na marami ng study na nagpo-prove, pero ito isang evidence lang na sinasabi na yung recurrence rate o yung rate ng pagbalik is halos parehas lang dun sa dalawa. So another study na nagsasabi na mababa, so as low as 2%, which is comparable again to breast conservation surgery. In doing MRM o yung mastectomy, ang recurrence rate rin is actually nasa ganyan din, less than 2% din. So pareho lang rin. Another surgical procedure that is associated with breast cancer is breast reconstruction. So ito, breast reconstruction should be offered to all patients. It is now the right of the patients to be made aware of all her surgical options. So it can be immediate, meaning right after the mastectomy, after matanggal yung breast, pwede na kaagad i-reconstruct, or delayed, which is after all the treatment, the adjuvant treatment, either chemo or radiation or both, po pwede rin yung delayed. So the options are doing an autologous tissue reconstruction or flaps, or implant, using an implant, yung mga silicone. Kung immediate breast reconstruction ang balak, we can do yung skin sparing mastectomy and the nipple sparing technique, no, for better cosmesis. So this is an example of an autologous tissue reconstruction. This is a TRAMPLA. This one is an example of implant reconstruction. So I will not dwell more with the technique. No, I just want to inform you that breast reconstruction is a viable option after breast removal. So I mentioned yung skin sparing mastectomy. Kung makikita nyo yung modified radical mastectomy, tinatanggal halos majority ng skin. So magiging ano na siya, parang flat na siya talaga, no? Sa skin sparing, so from the word itself, pinipreserve namin yung majority ng skin, no? It removes the breast, parenchyma pa rin yung mga breast tissue, but it preserves the nipple, the majority of the original skin envelope, followed by reconstruction. While yung nipple-sparing mastectomy naman is skin-sparing mastectomy, pero pinipreserve yung nipple areola complex. So advantages niya, syempre improve yung cosmesis, andun pa yung nipple, may nipple sensation pa. Contraindications are evidence of tumor involvement in the nipple and those with Paget's disease. So ang issue naman dito is yung tumor recurrence and yung kung mabubuhay ba yung nipple na iniwan, no? Yung nipple areola complex necrosis. So may I'll show you some evidence lang, no? So this is one study from the archives of plastic surgery, yung local recurrence rate, yung pagbalik, yung recurrence, 2.38% lang, and then the nipple necrosis rate is 5.9%. So another study, no, showing that skin-sparing mastectomy and nipple-sparing mastectomy has no difference in overall survival, disease-free survival, and local recurrence amongst patients with early-stage breast cancer. So the recommendation is for nipple-sparing mastectomy, dapat yung mga tumors peripherally located, ibig sabihin malayo sa nipple, smaller than 5 cm in diameter, and yon, no, located more than 2 cm away from the nipple margin. Okay, so I included this in my lecture because marami akong mga pasyente na nagtatanong, they express their desire to have their opposite breast removed also. So contralateral prophylactic mastectomy is the removal of the breast opposite to the breast diagnosed with cancer. To give you a background about contralateral breast cancer, ibig sabihin yung kung magkakaroon ng breast cancer dun sa kabilang side, no, which is the main reason bakit nagre-request na patanggal yung kabila, diba? So approximately mababa lang siya, 0.6% per year. Okay? It is lower in patients na nag-undergo ng adjuvant treatment, no? So we owe it to the improvements in the systemic and endocrine treatment that the risk for contralateral breast cancer is reduced significantly. Okay. So what are the risk factors for contralateral breast cancer? So family history, gene mutation status, and then age. So it is highest dun sa patients younger than 30 years old and patients with multiple affected first and second degree relatives. Those with BRCA1 and 2 mutations, they carry the risk of 30 to 40% of contralateral breast cancer at 10 years. So, what are the oncologic risks for CPM? It may negatively affect oncologic outcomes for patients who were never destined to develop a contralateral breast cancer. So baka hindi ka naman talaga magkakaroon. So tapos pinatanggal mo pa. So yan, ito, surgical complications. Pwede kang magkaroon ng surgical complications which can delay the onset of the adjuvant treatment. Okay. So in the US, no, meron yung American Society of Breast Surgeons. Yung consensus nila, yung for contralateral prophylactic mastectomy, dapat dun sa mga meron lang yung mutation ng BRCA1 and 2, yung may strong family history, yung may history ng chest radiation before the age of 30. Sa NCCN, which is one of the guidelines na palagi rin nababanggit among us sa mga doctors, they recommend it to women 35 years old or younger and carriers of BRCA1 and 2 mutation also. Though they said that it should only be considered after appropriate risk assessment and counseling. Otherwise, it is discouraged by the panel. So, again, the important thing here is that you explain everything to, we usually explain everything to the patient. In the end, it is still the patient who has the final say on what they want for their body. Next, we are done with the breast, yung surgical procedures for the breast. We will now go to the axilla. Pag pinag-uusapan kasi ang surgery for breast cancer, usually separate, although hindi mo pwedeng paghiwalayin yung management sa breast and management dun sa axilla. So for the axilla, dalawa yung pwedeng gawin. Yung axillary lymph node dissection, I already mentioned this during yung part ng mastectomy kanina. So for this part, we will go to the sentinel node biopsy. So sentinel node biopsy is regional therapy for women who are both clinically and pathologically node negative. So meaning by PE or physical examination, ultrasound, and mammogram, walang nakitang lymph nodes, tapos yung bukol nila maliliit lang. No? So usually less than 5 cm na bukol, tapos walang palpable na axilla. Pwedeng i-offer ang sentinel node biopsy. So ang ginagawa dito, nag-i-inject ng dye doon around the tumor or around minsan around the nipple o sa balat ng nipple. And then yung dye na yon, tatakbo siya doon sa pinakaunang kulani ng axilla. Pagkatapos i-inject yan, usually after 30 minutes, ang gagawin namin surgeons, we will try to locate for that node. Usually magiging kulay blue yung kulani na yon. We usually get mga 4 minimum na lymph nodes, then ipapa-examine yon sa pathologist. And then kung mag-positive, then we decide kung kailangang tanggalin lahat ng kulani sa axilla, yung levels 1 and 2, yung sinabi ko kanina, or po pwedeng iwanan na lang. May ibang ways pa para gawin yung sentinel node. Aside dun sa dye, meron yung radioisotope. No? So kaya lang yung kailangan ng special na machine. May mga ganun na sa ibang hospitals. No? Dito sa atin, wala pa kasi rin gumagawa. So, again, no? So, T1, T2, pag sinabi mong T1, it is less, yung tumor is less than 2 cm. Pag T2, 2 to 5 cm. NO, ibig sabihin walang kulani. No? Pag negative yung sentinel node na nakuha, ibig sabihin 98% ng mga natitirang kulani doon sa axilla, negative na rin. No? So, current identification rate, 95%, and the accepted false negative rate is 5%. Okay. Indications, para inulit lang to. So for tumors na less than 2 cm and tumors with 2 to 5 cm, tapos for the nodes, dapat non-palpable, walang nakakapa or walang nakita sa ultrasound and mammogram. Kung halimbawa may nakita na medyo malaking kulani, kailangan ma-biopsy siya. Usually FNAB. Dapat may it is biopsy proven na negative yon, na inflammatory lang siya. It can also be used for DCIS, yung ductal carcinoma in situ, yung stage 0 na sinasabi. If you are going to do mastectomy or in DCIS na medyo suspicious or may proven na micro-invasion. So, it is already part of the recommendation in breast cancer management that in patients with who underwent sentinel lymph node biopsy, so kung ang nakuha is nag-positive is 1 or 2 lang na sentinel node, considered negative pa rin yun. So pwede nang i-forgo yung axillary surgery, yung tatanggalin mo yung karamihan ng kulani sa kilikili. No? Kasi ang isang iniiwasan natin yung lymphedema. If you are familiar, no, may mga nakikita kayo yung lumalaki yung mga kamay after ng breast surgery. Usually the incidence is less than 20% kapag nag-undergo ng mastectomy. But it can go as high as 50% in patients na may mastectomy na tapos nag-radiation pa. So yun ang isang reason bakit na-develop itong sentinel node biopsy, yung parang sampling na lang ng lymph node instead of removing majority of the lymph nodes. Okay. So sa ngayon, contraindications, yung mga locally advanced or inflammatory breast cancer or those with allergy to the dye that is being used or yung isotope. Although meron ng mga studies na nag-aaral ngayon na after mabigyan, halimbawa inuna yung chemo for cases just like this, after baka pwedeng may role na rin yung sentinel node biopsy. Pero hindi pa siya part ng recommendation. In the future, pwedeng malamang papasok na rin siya as part of the indication. I think, to conclude, no, aggressive multimodality treatment in the form of surgery, combination chemo, surgery, hormonal, radiation, immuno, and targeted has provided long-term disease control for many patients with breast cancer. General surgeons and surgical oncologists must be familiar with the wide spectrum of treatment options to allow for best surgical management of their breast cancer patients. I think I need to emphasize on this. No? Surgery doesn't have to be done first. Hindi porke merong kang na-diagnose ka with breast cancer, surgery na agad. No? Ilang beses ko na-mention ni Dr. Rojo, may role ang neoadjuvant treatment, meaning yung magkikimo ka muna or endocrine treatment na papaliitin. Meron kasi mga pasyente, pag nagpunta parang worried sila na bakit hindi pa ooperahan? Diba? Baka mas kakalat siya. So dapat maintindihan ninyo na hindi kailangan surgery kaagad. No? Sometimes iniiba-iba lang namin yung sequence. No? Kasi surgery, after ng surgery, magkikimo ka rin naman talaga. So ang ginagawa lang is inuuna muna yung chemo para makontrol yung breast and yung mga micrometastasis na kung meron man, then surgery pa rin. Diba? As long as hindi pa siya yung kalat talaga. So understanding the tumor biology and the different treatment option is critical in optimizing the clinical outcome and always include patient in the decision-making process. I think that's my last slide. Thank you.
Thank you, Dr. Mallen, for the very, very informative, very parang summary ng surgery for breast cancer.
Stop sharing na.
So I'd like to call on again Dr. Rojo. For the question and answer. If you have questions po, you may type it in the chat box.
Oh,
Ay, wait lang po. Ayan. Okay, sige. We have a question from Dr. Bernadette. When do you use mammotome, Dr. Mallen? First of all, siguro, what is mammotome? Ano ba yung mammotome? Para saan siya?
Mammotome is a device na, ano ko ba explain yan? Para siyang kinakayod eh. Kinakayod niya yung tumor and then parang hinihigop lang niya. No? Dati nagkaroon ng craze na okay siya eh. No? Pero ang problem kasi with mammotome, you will not be able to define yung margins. No? So if it is cancerous, hindi natin malalaman kung nakuha mo ba siya lahat or nakakuha ka ng tamang margins. So kaya hindi pa siya actually part ng recommendation ngayon eh. Siguro sa mga benign tumors po pwede muna siya. Pero with regards to malignant tumors, medyo kailangan ng strict before mo siya gamitin.
Okay. I think dyan din papasok yung the common myth of patients na pag ginalaw yung bukol, nagagalit. Lagi tayo nakakarinig ng mga pasyenteng ganyan. So maybe you can comment on that in line with the mammotome.
Yes and no. Actually, yung pag nag-biopsy ka, isa yan sa mga ayaw ng pasyente. Pag nagba-biopsy, pag tinusok daw kasi, pwedeng kumalat. No? Actually, whether tusukin mo yan o hindi, kung wala kang ginawa, kakalat talaga yan. No? Ako, ang dictum ko kasi when I do biopsy, dapat once na-release yung result, within 1 month or the earliest possible time, magawa mo na yung treatment na dapat. Either kung for outright surgery siya, dapat maoperahan mo na siya kaagad. Or if needed ng neoadjuvant o kailangan siyang makimo, then dapat magawa na rin kaagad yung chemo.
Thank you. Dr. Rojo?
I will comment on that. Common talaga yun. Ang dapat na nagagalit ikaw, yung patient. Usually that happens when a biopsy has gone wrong or yung sinabi nga ni Dr. Mallen, natagalan. Usually, the usual timetable kasi is when you find it on mammo on the very same week, you plan for the surgery, for the biopsy, and then within a week, you get the biomarkers. And dapat the following week, nag-surgery ka na or nag-start ka na ng chemo. Ganun ka-short yung time frame. Ang ideal na time frame is probably 2 weeks. No? Hindi lang natin magawa dito dahil meron pa tayong mga weak links. No? One is the laboratory. However, we're trying to bridge that. May bago naman tayong pathologist na mas mabilis magtrabaho than yung before, no? na overhaul na nila yung systems natin sa laboratory. Ako, pag sometimes pag nagmamadali ako, send out kami para mabilis, no? Kasi minsan logistical lang naman yung problema eh. So, but really, yung time frame yan eh. Yung kailangan habulin mo 2 to 3 weeks maximum.
Thank you, Dr. Rojo. You mentioned sonomammogram. Pareho po ba siya as a digital mammogram? Kasi isang deterrent yun for patients, yung pain during the procedure. But I'm familiar with an institution in Manila na nag-aano ng digital mammogram. Is that the same advantage, Dr. Rojo?
Actually, yung digital mammogram as compared to yung older technology machines, parang it's not an issue anymore, no? Ang assumption ngayon is lahat ng systems are digital. Ang difference lang naman dun is mas accurate yung image. Siguro they press less, no, when you're using digital, but it doesn't necessarily mean that nobody now complains anymore. So kasi we're using it more and more, mas maganda actually yung image that you get in digital mammogram pag mas dense, no? Kasi mas ano nga siya, mas pag mabata ka kasi dense yung breast, that's why supplemented na sila, both mammo and sono, we use them. And then pag really dense, sabi nga ni Dr. Mallen kanina, that's when papasok yung MRI.
Thank you. That's why meron din siyang cut-off when you usually don't request for mammogram, or when you just request for an ultrasound. Kung mas bata, ultrasound. Pagtantong ng 40, which is the recommended screening ngayon, combination na sonomammogram. Okay. Dr. Mallen, what if a patient, yan talaga, minsan takot magpa-biopsy, masakit, di ba? Pipilitin nila yung FNAB, yung injection lang. Can you comment on the disadvantage of an FNAB? And if kung kunyaring ayaw magpa-core needle, is there another way to do the biopsy na hindi masasaktan ng pasyente?
Okay. Before the advent of core needle biopsy, ginagamit din naman ng FNAB. So, hindi naman natin siya inaano talaga na wala siyang role na ang FNAB. So, before yung mga core needle, meron pa, yun ang usual na ginagamit. Very easy, syringe lang siya. No? So, ordinary syringe, 10cc syringe, pwede mo na siyang magamit. Ang problem lang kasi with doing the FNAB, ang makukuha mo lang cells. No? So, cells lang siya. Compared to a core needle biopsy, wherein you get para siyang strips of tissue strips. No? Again, the importance of that is we will know not only whether that mass is cancerous or not, but also we can request for the breast panel, which is, again, to emphasize, very important in the decision-making process for breast cancer. Other options na sinasabi mo, no? Kung ayaw niya masaktan, ang isang option is kung mag-excision, ganun din, mas masakit. Incisional, ganun din. Another option is doing it parang one setting, no? Lalo na yung mga BI-RADS 4 or 5 na tumor, you can have it done parang one setting. We can do the biopsy in the OR, no? We will proceed directly to excision, no? Excision, then we will send it to, so tulog kayo, so walang mararamdaman, send it for frozen section. So usually 30 minutes to 45 minutes, may results na, alam na kung malignant siya, we can proceed with the either a breast conservation or mastectomy. Ang problem lang dyan, you will never know kung ano kung triple negative siya, which is may benefit sana ang neoadjuvant. No? So ito yung mga factors na kailangan i-explain sa pasyente before deciding talaga for surgery.
Thank you. Available ba ang wire needle in our setting? So, just to emphasize, we are reiterating, ito po yung advocacy ng OCMS is really for screening and early detection of cancer. So, kung kunyari naman, walang sumusunod ang pasyente, very, yearly na screening mammogram, what if may na-detect? Meron bang available na wire needle dito sa setting natin? Or if none, saan po pinakamalapit?
Sa akin kasi, most of the patients na ginagawa ko na wire needle sa Manila eh. Yung parang wala, ang gumagawa kasi ng wire localization or needle localization, usually yung radiologist eh. Yung mga breast radiologist eh. Dr. Guevara, yung radiologist na si Dr. Guevara, nagkaano siya ng mga interventional procedures also, pero yung availability nung needle, hindi ko alam kung meron. So hindi pala most, parang
Almost all.
almost all ng patient ko sa Manila ko dinadala kung kailangan ng wire localization.
Dr. Rojo, do you have are you familiar with an institution?
Ako, I send my patients to one big hospital in Manila wherein meron silang breast radiologist.
So talagang Manila. Wala tayong choice kung sakali. As of now. Okay. We have a question in the chat box. Is it possible to have breast reconstruction even after 2 years? And how much?
How much?
Uh,
Yung how much, hindi ko masasagot siguro. Unless nandito ba sila Dr. Karandang? Wala. Dr. Doble. So, yung timing, 2 years, actually pwede. Ang problem lang with that is medyo baka yung balat ay masikip na. So, meron naman silang mga ginagawang procedure to loosen up yung skin. Naglalagay sila ng expander. No? So, before putting yung flap or yung prosthesis. So, may ways para magawa. So, yung for the question kung kahit 2 years, yes, pwedeng ma-reconstruct ang breast kahit na 2 years na. Yung sa price, hindi ko masabi kung magkano eh. But meron tayong 2 plastic surgeons in Olongapo, so Dr. Karandang and Dr. Doble na they are very good in doing breast reconstruction.
and mas makakasagot ng price.
Yes.
After 2 years.
Kasi yung iba baka akala nila wala tayong plastic surgeon sa Olongapo. Meron tayong 2 specialist.
Thank you. To Dr. Rojo, this may be a common question, but I think it's very important to relay. Ano ba yung mga usual side effects ng chemotherapy?
Okay. Usually when I give any patient chemotherapy, para may idea lang sila, para sinasabi ko, easy, medium, and difficult, no? Yung mga protocols. Ang breast cancer protocols are in the easy, no? na category. So, most of the time, you don't really have to take leave from your work, no? Dapat actually kaya mong pumunta on your own. Medyo mahilig lang talaga sa TLC ang mga Filipinos, no? Kaya may bantay pa yan. Pero actually, kayang-kaya mag-isa. So, yung usual, no? The nausea, the vomiting, that's almost gone, no? In current era. Ang goal is 0 nausea and vomiting. If meron man konting-konti breakthrough, but then even if ayaw mo nun, may mga madadagdag na gamot to prevent that. Hair loss depende sa gamot na ginamit. There are a lot of protocols ngayon na if you go to our chemo unit, makikita mo marami may buhok. Pero sadly for breast cancer, most of the agents nakakalaga siya ng buhok. However, all these side effects, no, fatigue, most common yan, are reversible. But most pronounced are probably a little bit of fatigue. No? Adjuvant, we're talking about early breast cancer. No? A little bit of fatigue, skin changes, nail changes, none of which are going to be so bad. And yun nga, yung hair.
Okay, thank you. Para ma-alleviate yung fears of chemotherapy. Kasi nga, as you mentioned, do not be afraid to get tested. Also, do not be afraid to get treated. Kasi kailangan na kailangan. We doctors, hindi natin i-advise yung mga yan, kahit na alam natin may side effects. The benefits are greater than the risks or the side effects. Another question from the chat box. This is for Dr. Mallen. In the case of my auntie, nagpamastecto siya last year, mastectomy. After 3 months, nag-start po yung paninigas ng muscles around the part na tinanggalan ng breast. What could have caused it?
Tumigas, no? Pwede siyang fibrosis around the area. Yung minsan nagkakaroon ng pamamaga doon sa area. Actually, in any part of the body na magkakaroon ng sugat, laging may tendency magkaroon ng fibrosis o yung parang nagkakaroon ng peklat sa loob din. So pwede yun ang cause ng paninigas ng muscle na yon. So pero dapat medyo ano rin tayo dito kasi yung paninigas na yon, dapat sure tayo na walang bagong bukol. No? Na walang bagong bukol. Baka may sabihin tumigas lang yung balat. Yung pala, may infiltration na dun sa skin. No? So dapat ano rin yan. Pag merong part na ganyan, dapat constant follow-up pa rin with your surgeon so that he can assess, evaluate kung kailangan ng further investigation.
Okay. You mentioned about follow-up. I'll go back to Dr. Rojo. Paano po ang schedule ng follow-up for patients after chemo for breast cancer? Naoperahan na chemo. Paano po tayo nagpa-follow up ng mga patients? Gaano katagal?
Right now, intensive siya for the first 3 years. And then the third year to the fifth year, every 6 months na lang. And then after the fifth year, yearly. Yun yung standard. No? Pero mag-iiba yan, depende sa risk. Depende sa institution. Pero yun yung usual. The breast imaging is yearly.
Yearly. And how long before you label a patient na survivor na siya ng cancer?
I shy away from that mentality, that you need to make a declaration that I'm cancer-free, magti-Twitter ka, magpi-Facebook ka. Pressure yun eh. Consider you wanna consider yourself a survivor on day one, yeah. Even if the tumor is there, if I'm surviving, like I said earlier, like the pandemic, I will never concede a day of my chemo unit to this pandemic. So I will not, hindi ako talo, I'm a survivor immediately, di ba? So I try to veer away from that kind of mentality na you need to declare, Pero just go by the numbers, After the third year, your risks are lower, and then by the fifth year, near normal na yan. Kaya yearly na lang yung follow up mo. So again, the bigger the tumor, the bigger the risk, The treatments that you deny yourself, Baka sinabi ng chemo, hindi ka ng chemo, dinelay mo. This puts back some of those risks. So ang dami kasing factors really that come into play. And there's no one strict number that we can all go by. So a little bit complicated, but you wanna simplify it. Follow the recommendation.
Yeah. It's also the same pag sinabing may tanning na ba. Kasi iba-iba rin naman ang behavior ng mga cancers. So personally, ako rin, I shy away from saying na 6 months ka na lang or 1 year because we see patients na early stage pero they get recurrences 8 to 10 years after the initial diagnosis. So it's really hard to say talaga na talagang tapos na yung battle with cancer. Although there are a lot of patients who are really yung sinasabing survivors. Okay. Next, from the chat box, normal lang po ba makaramdam ng medyo makirot sa bust pero bihira naman mangyari? Parang gaya nung symptom na darating ang monthly period. So 5 years na akong menopause. What is the advice? Kailangan ba ng mammogram pero hindi ko pa nagagawa kasi masakit daw? Maybe Dr. Rojo can answer this.
You cannot be guessing on the breast, di ba? So clinical breast exam, if may duda ka na ganyan, and I think you had that. So ano yun? Periodic yun, kung ipina-follow up. But really, the answer is in the question itself. Do the mammo. Hindi siya ganun painful na you will regret it. At maybe at that moment, you feel a little pinch. Sino ba naman ang hindi nakurot? Stop worrying about the pain. It's not that painful.
Okay.
Yes, if I may add, so sometimes maraming pasyente na pumupunta sinasabi masakit ang breast, So tama si Dr. Rojo, dapat hindi pwede i-take for granted yung breast. So, kung makapag-mammogram at negative yon, sometimes yung cause kasi ng pain na na-attribute nila sa breast is costochondritis in the area ng ribs, no? So sometimes yun. So any pain reliever pwedeng gamitin kahit na paracetamol lang. So as long as walang nakita doon sa breast, yun yung importante. So okay lang na minsan may pain, basta nawawala, as long as walang suspicious na lesion. Dapat na-emphasize natin yun sa kanila.
Yeah, thank you. And I think this also will be this next question is also answered by that. For breastfeeding moms, usually may lumps, mga galactoseals. So anong pwedeng maipayo? Just like what you've mentioned, just go to your doctor. Kasi it might be na pwedeng nag-overlap lang or baka napansin mo lang at that point in time na may bukol ka pala during your breastfeeding. So it's still very safe to go to your kahit your OB or your physician just to have that check-up, physical exam.
Doon sa mga nagbe-breastfeeding, no? So common 'yan po pwedeng magkaroon ng galactoseel, yung naiipon yung gatas. No, sometimes kung talagang po pwede siyang i-aspirate, no? Hindi mo naman kailangan i-excise 'yon kung talagang Ang problem with breastfeeding, yung isa pang problem is yung risk of having yung mastitis, nagkakaroon ng infection sa breast. No? So it is treated with antibiotics. For galactoseel again, pwede rin mag-infect 'yon. So ang management aside from antibiotics is drainage. No? So either by aspiration or incision. So, depende. So importante na makita rin ng surgeon muna or ng doctors.
RJ, we have somebody in the audience na remember the last time we did this yung nag-speak for screening I know she's in the audience and she has a regular surveillance she's in a regular surveillance program. Maybe we can ask her later, no, if you have time to comment on the pain part, no.
Sige po, Doc. Okay. Yeah, for Dr. Rojo, is it necessary to undergo PET scan after all the treatment for breast cancer?
Not strictly just after, no. Depende kasi sa stage. It can be at the start, no, of the treatment. Kung stage 4, it will be at intervals. Pero for early breast cancer, it's not standard.
Okay. Dr. Mallen, if the patient decides to have prophylactic surgery, is it still necessary to have the BRCA testing?
Kung mapapagawa niya dito sa atin, yes. Hindi ko alam kung magkano Baka alam ni Dr. Ro kung magkano.
I can answer that, no. So for you to have the prophylactic mastectomy, you need the BRCA testing. So in BRCA testing actually costs less than 20,000. BRCA 1 and 2.
So parang nakikita natin yung opposite spectrum. Some patients gusto mag-breast conserve. Yung iba gusto patanggal yung kabila. So it's down to the patient's choice and preference. Basta yan emphasis on laying out all the options in the cards. And lahat ng possible surgery na pwedeng i-offer is equivalent in terms of yung survival and yung disease-free and recurrence rates. Okay? Ito medyo mahaba. I'll just say it verbatim. We also have a family history of cancer. Father's 2 sisters and my lola, mother all had breast cancer, and I think that could have caused their death. My tatay also suffered metastatic squamous cell carcinoma of unknown primary. Possibility of me and my siblings and my children have the same, very apparent. We have been exposed to the surgical side in the alternative ways. I have seen the plus and negative effects of both. Pwede po bang malaman on how you differentiate the two treatments? Medyo magkabalang spectrum kasi yan What's difficult, I think, Dr. Rojo, is yung metastatic squamous cell carcinoma, yung unknown origin.
Well, that's a lot of issues. That's a soup of fears.
Yeah.
That's yung paghiwa-hiwalayin natin yung dapat paghiwalayin. When it comes to risk for cancer, that's obviously, kung every generation of women in one line, yeah, you need BRCA testing. So in fact, you can go for an extended multi-gene testing, that will cost perhaps somewhere between 30 to 40,000. Plus genetic counseling, about mag-prepare ka na ng 50. And then you will know your own personal risk, kung ovarian, mukhang connected sila. Yung squamous, hindi siya connected doon. Most of the time, yung mga squamous cancers are lifestyle related. Most common dyan yung lungs, skin. So, however, that can suggest na meron general susceptibility gene as well. Ibig sabihin, really, you are recommended for extended na testing for mutations beyond BRCA1 and BRCA2, and the cost is that. Mainstream medicine versus alternative. Let's not go to that. No, that's a different issue. That's not a focus for today.
Okay, thank you, Dr. Rojo. We have any other questions? I think we discussed extensively yung mga ibang issues. Siguro one more point of emphasis for all of these lectures for breast cancer is it doesn't end with surgery alone. It doesn't end with chemo alone. If it's necessary to have radiation. Basta ang demographics, characteristics of breast cancer, iba-iba. Hindi porket yung kapitbahay mo na may breast cancer, ganun din yung treatment sa'yo. So that's the end all and be all of this. Parang medyo multidisciplinary. Na there are a lot of treatment options, and the treatment options are tailor fit to what you have, to what the patients have. Dr. Rojo, you were mentioning about the screening. So maybe you can ask your resource speaker na lang po to say a few words.
Yung
Lori, if
patient.
you're still there, the pain of mammography.
Ayan, opo. Medyo
Please unmute yourself, Ma'am Lori, if you're. I can see your name. Wait lang natin siya. Yan.
Hello po.
Go ahead.
Hello po. Good afternoon.
afternoon.
Yes, about mammography. Actually, yung sa mga at first talagang yun ang impression, masakit. Pero kasi yung alam mo yung feeling na uncomfortable ka kasi pinipress yung breast mo. Kaya may pain. Actually, yun lang naman yung masasabi ko na kailangan pag nagpa-mammography ka, iset mo na yung mind mo na kailangan relax ka lang, and yung matanggal mo yung sarili mo na yung kailangan maging komportable ka para wala kang maramdaman na pain. Kasi yung pain, at first, nandun pero saglit lang eh. Parang hindi naman siya magtatagal actually. Paglabas mo ng room, wala na rin siya. So, tama yung sinabi ni Doc, painless naman talaga. Yun lang po.
Thank you.
Thank you, Ma'am Lord. Lahat naman, first time eh. Parang takot magpa-opera, takot ng injection, takot ng test. But, na-overcome yung fear. Tama yung sinabi ni Ma'am Lori, no? It's sometimes really it's all in the mind yung pain. Okay? If there are no more questions, thank you, Dr. Rojo and Dr. Mallen. But we would like to hear a few words from proof that you can beat this dreaded disease, breast cancer. So may I now call on Ma'am Daisy, Miss Daisy Lorenzana, to share a few words on her battle and her journey throughout breast cancer.
Hi, good afternoon.
Afternoon.
Yes. My name is Daisy. I'm a long-time survivor. I was diagnosed with cancer October 3, 2008. So what can I say about my journey? Breast cancer can affect anyone. We should not, what can I? We are all at risk, even men, right, Doc? Even men. There are factors, of course, factors like being female. Number one is that being female. Number two, age, as I've heard kanina, sinabi rin ni Doc, age. Genes, it runs with the genes. When you have family member, a mother, grandma, aunt, sister who have had breast cancer, it's also a factor. Breast cancer is also one of the many causes of death among women. So it's kind of scary, but having all these facts, I think it's best to protect ourselves. Try to protect ourselves. That's for me, is my own secret. Try to protect yourself through education. Educate yourself. What else? Know the symptoms. Do self-breast exam. Ask your doctors. Do not be afraid to ask your doctors. Remember, all questions are good questions, right, Doc? And all our feelings are valid. All our fears, everything. Go to doctor. Do clinical breast exam. Do imaging, like what doctor said, mammogram, ultrasound, and most importantly and most especially, do the treatment. Follow your doctors, or shall I say, obey. Obey your doctors. Why? Because doctors are our healing partners. They are our healing partners. I believe that. In cancer, there are choices. I believe there are a lot of choices. You can hide it. You can hide it. You can deny it. You can keep it. You can be coward. Or maybe I can say you can be brave. Face it, fight it, and survive. My cancer journey, it is not a nice experience. And I don't want anyone or anybody to experience it. But you know, my cancer journey, it empowers me. It empowers me because I began to learn a lot. I read a lot. I search a lot. I ask a lot. And I told myself during that time when I was diagnosed, I cannot afford to be ignorant. I write notes. When I go to my doctor, I read all the notes one by one. I don't know if he's mad or what. I just read. I want to know more. I want to know a lot with my cancer. I could not afford to be ignorant. Knowledge is power. So, I guess everyone should learn from it. My cancer empowers me. Also, it's most importantly for me is to pray. Pray and pray. I believe also, I firmly believe that everything is a divine grace. Everything is a divine grace. No matter how much money you have, no matter how good all your doctors are, it's still with God. And I believe with that. during my cancer or my cancer journey brings me closer to my Creator. I had a taste of peace during that time. Kasi tahimik lahat eh. So, I learned to live a less intense life during that time kasi masyado rin akong, how do I say this? I internalized a lot of things. Kaya very stressful ang buhay ko. I learned to live a less intense life. I had a taste of peace. And I just learned to live each moment. I know that each moment is a gift. It's a gift from God. I know my God more. I know that my God is the God of life. So when I was asked to share a little about my cancer journey, I think that's all I can share. Know everything, know the facts, learn, be educated, and pray. That would be all. I don't know what else to say. If I will make kwento, I will talk a lot. Maybe we cannot finish on time, or I will be requesting a lot more time. So it's just a very short one. I think I can remember.
Yes, thank you. It was very beautiful. Thank you for that testimony. And it's one thing that you really strikes us is we are humans. We get sick. We have doctors. But at the end of the day, the doctors are just the instruments to healing. So
And
ginagamit.
one thing, Doc,
Yes, sige po.
I also wanted to add, it is also great that you can talk to people, not only to doctors. I mean, doctors are people, but talk to friends. There are a lot of support groups. There are support groups, they offer counseling. They can also give you, there's a lot of information campaign from all these support groups. There are cancer awareness. So talk to them, learn from their journey, or share your own journey with them, and be healed. Because all these support groups, I'm sorry if I'm so emotional, because all these members of the support group, you can heal from them. They are all wounded healers. They are all wounded healers. Heal from these wounded healers. That's all.
Very na-segue ko na rin po that I would like to also extend our greatest appreciation to the Subic Olongapo Cancer Foundation.
Yes.
This is a very tight group who helps each other, cancer patients, a bridge to the doctors and to each other. Na napakalaking bagay talaga na may nakakausap ka about your emotions and your feelings. Hindi lang medical side ang doktor eh. Actually, I think Dr. Mallen, Dr. Rojo, nakikilala nila yung mga pasyente very intimately because of the treatment that they're giving. Andyan sa chemo unit, mas ang dami nilang napapag-usapan, umaabot pa sa lolo, lola, kapitbahay. But it also helps in the growth of the patient, in the journey of that patient, na komportable siya battling through this cancer. So, maiksi lang yun, Ma'am Daisy, but it really helps a lot in telling the people here, all the participants, that you will never be alone in this journey if ever you have this disease. You're never alone. You have your doctors, you have your friends and families, and of course, your faith in God. So thank you, Ma'am Daisy, for that. Very lovely. Thank you. Now, before we end, I would like to ask a few final words from our speakers. Dr. Rojo?
Just to say thank you to all of you, and especially OCMS. RJ, good job.
Thank you, Dr. Rojo. Dr. Mallen, my friend, my senior.
Senior, kailangan i-emphasize.
Yeah.
Same, thank you for inviting me to be part of this breast cancer awareness, and to continue doing a good job. And to the patients, don't be afraid. talk to your doctors. Makikinig naman kami, no? On your concerns, etc. Yun lang. Thank you.
Thank you. So in behalf of the officers of the Olongapo City Medical Society, would like to would just like to share this virtual certificate of appreciation. This certificate is presented to Dr. Jaime Jesus Rojo for his valuable contribution to the Olongapo City Medical Society's cancer awareness advocacy, a speaker for his lecture entitled Breast Cancer Awareness, Prevention, Early Detection, and Treatment, given this 23rd of October in the year of our Lord 2021, signed by Dr. RJ Manzo, Secretary of OCMS, and yours truly as the President. Thank you so much, Dr. Rojo. Likewise, a certificate is presented to Dr. Richard Mallen for his valuable contribution to the Olongapo City Medical Society's cancer awareness advocacy, a speaker for his lecture entitled Surgical Management of Breast Cancer, signed by Dr. RJ Manzo, Secretary, and yours truly. Thank you, Dr. Mallen. And lastly, to a certificate of appreciation to Ms. Daisy Lorenzana for her valuable contribution to the Olongapo City Medical Society's cancer awareness advocacy in sharing her experience and journey as a cancer survivor. Again, signed by Dr. RJ Manzo, Secretary, and yours truly as the President. So again, thank you, everybody. So to close this activity for this afternoon, we would like to call on our Vice President, Dr. Jerome Michael Acosta.
Hello, good afternoon to everyone. Yes, first, I would like to thank our speakers. Those are very wonderful lectures you've given. So Dr. Mallen and Dr. Jim Rojo, thank you so much for sharing the afternoon with us and for the knowledge you have imparted, for the experience. So I believe that that still early detection in any case of malignancy or cancer, ang pinaka maganda pa rin pong mode of treatment is still prevention. So the earlier to detect the cancer, the better. And to Miss Daisy Lorenzana, thank you for sharing your experience. So I think every journey, be it your cancer or any journey for that matter, we all have unique experiences. These are all religiously unique. They are medically unique. The tumors, no two tumors are exactly the same. So the treatment, the management, they're always different. And correct, yung sinabi ni Ma'am Daisy na yes, there are always people who are willing to support. There are support groups. There are people willing to share their experiences, no, to make you the journey be a better one. And yun lang po sa lahat po ng mga advocacies na regarding the cancer. The goal here really is to ultimately save lives. And through information, through facts. And we hope you join us sa aming mga iba pa pong lectures. And until then po, marami pong salamat ulit for sharing your precious time with us. And God bless po sa lahat.
Thank you po sa lahat. May I request na lang po for all the audience to open their videos for a screenshot lang. Again, maraming salamat po. Next week, we have our uterine and ovarian cancer lecture.